I'm very interested and excited for our speaker this afternoon, Dr. James, to talk with us about principles of pharmacologic and interventional management of cancer pain. So Dr. Dominika James graduated residency in anesthesiology at UNC Chapel Hill, followed by completion of fellowship in pain medicine at Duke University. Dr. James has been on the UNC pain medicine faculty since 2010. She is now serving as the UNC Director of Pain Fellowship. So thank you, Dr. James, for joining us this afternoon. So outside of your professional biography, something interesting you'd like to share with us or personal?
Well, I am essentially an animal lover, animals of all kinds, and I have a lot of pets at home, including 2 guinea pigs, Lola and Pineapple. As well as some other critters, doggies, so on and so forth. And in my spare time, whenever I can, I love to travel with my family as far as the plane can take me and visit exotic worlds. So most recently, we went to Africa and had an opportunity to hang out with some amazing animals over there and swim with sharks and, saw some elephants. So that was great. A few years back, we did the same thing in Australia, and that's what truly rejuvenates my soul and makes me happy in life.
That sounds a little scary, but exciting at the same time. This is an example of our Poll Everywhere questions. You will have an opportunity to practice. So your first question to practice on is: cancer patients rarely suffer from cancer-related pain. True or false? In the meantime, I will read our disclosures. This activity has been planned and implemented under the sole supervision of the course director, Dr. William A. Wood, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina at Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. A potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which they have a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with any commercial interest pertaining to this activity. So let's circle back to our Poll Everywhere question. Cancer patients rarely suffer from cancer-related pain. 100% false. I think they did okay with our practice. So thank you all for participating.
Absolutely. And of course, this is a correct answer. Otherwise, I wouldn't be here today. And I am so grateful that I have this opportunity once again to come and speak on the Cancer Network. Thank you so much for inviting me. As mentioned, I have no financial disclosures to make. And during today's talk, I would like to focus primarily on interventional pain procedures that one can utilize for cancer pain management, as I realize that those are topics that perhaps do not get covered much. We are going to also discuss some pharmacological approaches, as well as briefly review etiology of cancer pain. So as you all know, cancer remains the leading cause of death worldwide. Essentially, 1 in every 6 deaths is attributed to cancer. However, despite tremendous accomplishment and advances in terms of treatments available for cancer pain, cancer pain remains largely undertreated, and that is particularly pronounced in the underdeveloped country. So approximately 60 to 90% of patients with advanced cancer do suffer from significant pain. And what's really sad about it is that if analgesics were provided to those patients, it is estimated that 80 to 90% of those patients would obtain adequate analgesia. So clearly, there's a lot of disparities in terms of cancer pain management. In particular in the underdeveloped countries. What's really striking about this graph that I present to you is that despite the fact that USA constitutes only 5% of world population, we are consuming over half of the opioids prescribed for cancer pain management. In comparison, if you take the third world countries, the countries beyond USA, Canada, and Europe, they constitute 72% of world population, yet utilize only 6% of prescribed opioids. So clearly there is a lot of disparities in terms of access to care, in particular access to care for patients with pain related to cancer. Now, why is this happening? In many instances, it has to do a lot with international drug controls laws and politics. As we know, in third world countries, there's a lot of corruption, and the countries are overall very poor. So there may not be access to much of analgesics of the type that we clearly have easy access to in the United States. Saying that, we also have a lot of disparities in terms of access to care within United States as well. And many of patients suffering from cancer in our country also experience challenges of obtaining adequate amounts of opioid and non-opioid medications for cancer pain management. That is very often associated with ignorance of policymakers, as well as poor training of healthcare providers, which are often in fear of legal sanctions if they choose to prescribe opioids to patients in pain. First question, when discussing cancer pain care with a pancreatic cancer patient, what can you tell the patient regarding the cancer-related pain? Most cancers are not associated with pain. For many cancer patients, access to care and pain management remains difficult. Physicians have no obligation when prescribing opioids for cancer pain. No inhibitions. Most patients who suffer from advanced malignancy achieve adequate pain relief. So the B is correct. For many cancer patients, access to care and pain management remains difficult. Although I do agree, some patients are lucky enough to obtain adequate pain control when they're suffering from cancer. For majority of patients, it is not the case. Okay, we'll move forward. So before we can discuss various therapies available for treatment of cancer pain, first let's discuss what is it about cancer that causes pain in the first place. In most cases, it is the underlying disease itself. However, we also have to acknowledge that many of the therapies we use for treatment of cancer often contributes to severe pain, severe post-operative pain, severe post-chemotherapy pain. All of those things may ultimately lead to chronic pain, even in patients who survive cancer and move on with their lives. So in this particular case, the pain is secondary to acute fracture resulting from invasion of cancer, invasion of malignancy into the pelvic bones. And the patient might have originally felt just some kind of dull, achy sensation in their pelvis until the fracture occurred. And then, of course, this was associated with severe acute pain and inability to ambulate. Many cancers, as they invade various tissue, tend to expand. This can further lead not only to tissue destruction, but tissue expansion, tissue invasion, often with compression of surrounding structures. So as it is a case with this particular CT scan, the expanding tumor clearly by growing has obliterated venous vasculature within the neck. So on the left side, you can see preserved patent artery and vein. However, on the right side, which is this side, you can only see that the artery is still patent, but the vein is largely obliterated. That can further lead to swelling, edema in certain aspects, as well as hypoxemia of the tissue, which leads to disruption of neural conduction, nerve injury, and hypoxemic pain. Now, how about visceral cancer pain? Solid organs, when invaded by cancer, are initially not particularly painful until the cancer grows large enough where the capsule surrounding the organ expands and causes significant discomfort and abdominal pressure. So clearly you can see on both of those images, this is a cancer of liver, which has grown significantly and now causes significant discomfort to the patient. When it comes to hollow viscous, it is usually the obstruction of the hollow viscous by cancer leading ultimately to distension of the part of the viscous that is proximal to it that causes to the discomfort. Now, what about pain following cancer treatment? I know that you guys are quite familiar with all different things that chemotherapy can lead to, and probably one of the most prevailing sort of leftover symptoms from chemotherapy is chemo-related neuropathy, and it can be quite devastating to many patients. In an acute setting, of course, radiation therapy can be extremely painful as it causes burns to skin and underlying organs. But this can also manifest in the long term in chronic pain as related to chronic injury to those structures. So in case of this particular patient who clearly underwent radiation to the neck, possibility of development of plexopathy, which means burn injury to underlying neural plexus, can chronically lead to persistent upper extremity pain. Radiation also frequently causes mucositis. I have a lot of patients suffering from this condition, which can lead not only to pain, but malnutrition and suffering from dental caries. But there's nothing more pain-related than cancer surgery. And I tell you, after being in operating room for over a decade, there's no other surgeries that are more drastic, truly more debilitating for the patient and more painful than cancer surgeries. I mean, clearly, as you can see on those images, it's truly amazing that we are able to even perform surgeries of this nature. Now, when surgeons consent patients for surgery, it is really very rarely that they touch on possibility of post-operative chronic pain. But post-operative chronic pain is extremely common. Look at the percent of patients who develop chronic pain post-amputation, 30 to 50%. And actually in acute pain setting, immediately post-amputation, up to 90% of patients experience phantom limb pain, which then ultimately abates over time. Any surgery to torso, surgery such as thoracotomy, mastectomy, even upper abdominal surgery also has a very high risk of post-operative chronic pain. So those are not low numbers. Ultimately, when you take all various therapies provided to patients suffering from cancer, there is approximately 1 in 3 risk that those patients will develop chronic pain that they will suffer from. So this is certainly an important issue and something worth addressing. So we have our second question. Cancer-related pain can be a result of all of the below except underlying disease, chemotherapy, surgery, spinal degeneration, and ischemic injury. All of those except. All right, I think everybody has placed their vote. Oh, things are still changing. So definitely, although spinal degeneration causes pain, the question asks which of those which of those are related to cancer, and spinal degeneration is not part of it. The underlying disease, meaning direct invasion of tumor into various tissues, certainly can cause pain, as is ischemic injury related to vascular obstruction by cancer. So why are we even talking about pain control? Well, the answer is truly quite simple. We would all not go to nursing schools, medical schools, whatever schools you might have finished. We wouldn't put so many years of training and education not to help people. This is precisely why we went into medicine, to help those that are in pain. So if nothing else, definitely, helping patients in pain is simply our moral obligation. But there are also physiological reasons. There are also outcome reasons why we should provide adequate care for patients' pain in both perioperative setting as well as in terms of chronic cancer-related pain. So in terms of perioperative setting, as many of your patients will have surgery, what you need to know is that proper perioperative pain management not only allows for early mobilization, enhanced recovery, and early discharge home for the patient, but it also leads often to better cancer outcomes, as well as what's particularly important to me is chronic pain prevention. I have just told you how important or how frequent it is that patients develop pain following cancer surgery. So clearly, proper pain management perioperatively is of utmost importance. Now, in terms of chronic cancer pain, the management of this pain is important as it is the number one most distressing symptoms of those suffering from cancer. Patients suffering from cancer are concerned that any type of progression in terms of their pain may signify poor prognosis or even impending death. Pain decreases their autonomy, enjoyment of life, quality of life, and it's a challenge to their dignity. So it is our obligation to provide them the best care we can, not only for their cancer, but also for their cancer-related pain. Now, let's touch on briefly on various types of pain. Pain can be defined either in temporal or causative fashion. So usually we talk about pain in a temporal fashion as either acute or chronic. So essentially every pain that's sort of less than 3 months in duration is considered acute, and then everything beyond that is chronic. Acute pain is actually physiological and serves purpose. When you're walking down the hallway and you stub your toe, that stub, the pain related to stubbing your toe, tells you that perhaps you should not be kicking this wall as it's going to cause injury to the tissues of your foot. Yes, so then you withdraw your foot and everything's hunky-dory. Ultimately, the pain resolves, tissue heals, and you're all good. Well, it's all good until it isn't. Because in some patients, unfortunately, despite tissue healing, despite resolution of injury, the pain persists. And this is when we talk about this chronic neuropathic pain that is often so debilitating. By definition, neuropathic pain is pain secondary either to neural injury or to neural dysfunction, both at the level of the central or peripheral nervous system. Neuropathic pain is very different from nociceptive pain. Nociceptive pain is the one from stubbing your toe. Nociceptive pain is, quick on, quick off. It throbs, it aches for a little bit, but often resolves with time as tissue heals. Neuropathic pain, on the other hand, is solely pathological. It serves no purpose at all besides tormenting our patients. It feels different. It's often burning, tingling, lancinating in nature, and often associated with various skin sensation, with paresthesias, allodynia, hyperalgesia, which is essentially increased sensitivity of pain. And the worst part about neuropathic pain is that it is so challenging to treat. We are happy when we provide patients with multimodal management when we attain approximately 20 to 30% improvement in neuropathic pain. It is a true challenge. And even worse, it does not respond to the regular oral analgesic that we so frequently use for chronic pain patients and for chronic cancer pain patients, such as opioids and NSAIDs. Next question. So common characteristics of neuropathic pain include all of the following except pain is described as burning and lancinating, pain that persists despite resolution of injury, pain localized only to visceral organs, pain that is difficult to treat, pain that may be associated with sensory skin changes. You guys are absolutely right. Neuropathic pain can occur anywhere in the body, can be associated both with visceral as well as somatic organs. Okay, well, finally, we arrive at the principle of cancer pain management, and we'll start with few cases. I have either 3 or 4 cases to discuss, depending on how fast we're able to go through it. So let's talk a little bit about opioids, because it's such a hot topic. We live in an era of opioid epidemic, and it's a true issue that should not be ignored. But I think that some of the principles that apply to general population in terms of utilization of opioid medications do not necessarily apply to the same degree to cancer patients. And unfortunately, I think that cancer patients often suffer as a result of the limitations placed on physicians, on various prescribers. And there is actually a misunderstanding that the laws that are being passed also apply to cancer patients, which in some cases they do not. I'm sure you are all familiar with the STOP Act that was passed in the state of North Carolina that limits prescribing of opioids for acute pain, either to 5 days or to 7 days postoperatively. That does not apply to chronic pain. That does not apply to cancer pain. The opioids still remain the #1 cornerstone treatment for cancer pain. And they should not be avoided at all costs, as they are the only medication truly without ceiling that can provide our patients with adequate pain control. However, we cannot forget that opioids are not be-all. And unfortunately, I very often see cancer patients coming to me, to my office, being only on opioid medications. And although I will not be able to touch on all different aspects of multimodal analgesia, we'll only talk about medications and procedures today. I want to emphasize how important it is to provide the patient with all aspects of care, including rehabilitative care such as OTPT, psychiatric care, psychological counseling, complementary medicine, and all other social aspects of care. Now, why is multimodal analgesia so important, and how does it help? It improves pain control, offers opioid sparing, so patients use less opioid medications, which is also associated with decreased opioid-related side effects. It provides better overall pain control with fewer analgesic gaps, and overall improves functional outcomes. I'm sure you are all well familiar with World Health Organization cancer pain treatment ladder. This ladder has been in place since 1986, and we are all very familiar with it. However, it appears quite simple to us. You know, in a third world country, there's an access to very few medications available to those suffering from pain. I know in Poland, where I'm from, it's mostly aspirin. We didn't even have Tylenol. And I guess if you were really, really sick in a lot of pain, you had access to morphine. But that was pretty much it when I was growing up. We are so lucky to live in the United States, where the options are truly limitless. So this is from a Cleveland Clinic publication. And I just wanted to point out to you how many different analgesic options we have for treatment of pain. Even for mild pain, it's NSAIDs, it's Tylenol, corticosteroids, antidepressants, bisphosphonates for bony lesions, anticonvulsants. We are so lucky to have those options, and therefore we have to focus on utilizing all of them when prescribing for cancer pain management. Now, what I will focus today is mostly the interventional aspects of care that are highlighted here, and we're going to review some cases as pertaining to those. So case number 1, we have a 38-year-old lady with invasive cervical cancer. The patient is currently on Celebrex, Tylenol, and takes oxycodone as needed at 15 milligrams approximately every 6 hours. She claims to receive benefit from oxycodone, but reports inadequate duration of relief. So essentially, the pain waxes and wanes, and she experiences more pain between the doses of oxycodone. What is your plan? And I wish we could chat directly with each other here and have a bit more involved discussion, but I realize that's not possible. So I'll just continue with some answers. So for this particular patient, what would be very beneficial is to provide her with an extended release opioid formulation. She does respond to oxycodone. It seems to be providing great analgesia. So there is no need to consider opioid rotation. We simply need to add a long formulation of oxycodone to her overall regimen. Now, how do we do that? You guys are probably well familiar with it as well. You take all the short-acting PRN medication, all those opioids, you put them together, and in her case, we get a total of 60 milligrams of oxycodone per day. If you use twice a day dosed medication for time-release formulation, such as OxyContin, that would equal to 30 milligrams in the morning and 30 milligrams at night. But then you ask yourself, well, how do we come up with the proper dose for the short-acting medications? Because she will also need something for breakthrough pain. The rule of thumb is that you take all these long-acting MMEs that you prescribe. So in her case, she's getting 60 milligrams of opioid, 60 milligrams of oxycodone, and you calculate 10 to 20% of that dose and then provide it PRN. So she's taking 60 milligrams of OxyContin, so that would be 10% would be 6 milligrams, 20% would be 12 milligrams. So I think providing her with 10 milligrams of oxycodone PRN, somewhere in between, would be appropriate. This patient also suffers from insomnia. She's not sleeping well at night, and TCAs are fantastic for it. She is young. She's able to tolerate side effects related to amitriptyline. She will likely not get too sedated. So I think starting with a very small dose, maybe 10 to 20 milligrams at night, would help her with insomnia as well. So the patient returns 1 week for a follow-up. She reports improved overall analgesia and sleep, but continues to experience burning abdominal pain. She did have prior abdominal surgery for her cancer, and it's really, this pain is very much situated peri-incisionally. What are your ideas for treatment? Neuropathic agent of some sort would help. So this patient is already on amitriptyline. You could consider increasing amitriptyline. However, probably adding another agent would be to her benefit as well. So what I have decided to do for your sake is start the patient on gabapentin. If you start gabapentinoids slowly and titrate them up, patients tend to tolerate them well and avoid side effects. There's, of course, some somnolence and dizziness associated with all those non-opioid medications that help with pain. But again, start low and go slow, and most likely will avoid a lot of those side effects. So we're going to start this patient on gabapentin. The patient calls back after 3 weeks of taking the medication, and she reports overall improved pain control. She escalated gabapentin to 800 milligrams 3 times a day, continues on amitriptyline at night, which significantly helps with insomnia. Unfortunately, 4 months later, the patient suffers a bit of a setback. She's admitted to hospital for severe pain and colonic obstruction due to tumor progression. She clearly escalated her opioid doses, and even though those are not helping much, she's continuing on her adjunct medication, but also with no benefit. You're trying to help her, and you start her on hydromorphone PCA. You start at 0.2 milligrams every 10 minutes. You escalate to 0.5. You start her on a continuous rate. However, despite your best efforts, it's not helping. So we're in a little bit of a pickle. However, we do have some medications available to us on the inpatient service that were not previously available and that can certainly help. And ketamine is one of those medications. At UNC, both UNC Pain Inpatient Service as well as palliative care have access to providing ketamine, continuous ketamine infusions to patients that are hospitalized with severe pain. Ketamine is an anesthetic drug. It is an NMDA receptor antagonist. However, at small doses, it works magic for patients who do not longer respond to opioid analgesic for treatment of their pain. I usually start ketamine at a very low dose, no more than 0.1 milligram per hour, for patients that have intact renal function. I have learned over time that, although you can escalate it quite high, I've seen some people cranking it up to even 0.8 milligrams per kilo per hour. It doesn't help that much more analgesia, yet it is associated with a lot of side effects, and the side effects can be quite unpleasant. So I'm trying to stay below 0.25 milligram per kilo per hour to avoid bad dreams, dysphoria, and hallucinations that may occur. Unless somebody has severe cardiac disease, ketamine is actually quite safe. You do have to dose it renally with somebody with renal impairment. Ketamine, on this slide, I wanted just to show you a few different studies showing that clearly for opioid-dependent patients, ketamine is beneficial in treating chronic pain. Okay, so which adjuvant medication, when administered for pain management in an opioid-tolerant patient, showed the best efficacy in a hospitalized setting? Thank you. Great answer. Okay, we're going to keep going. I'm sorry. So the patient reports some relief after being started on ketamine. However, the pain is still severe. Clearly, it becomes clear that the patient should be transitioned to palliative care, and the patient is interested in anything you can possibly offer her for treatment of pain. She's hospitalized. She is suffering a lot. So what can we do for her?
Something went wrong. Please try again later.
I'm sorry, I'm not sure why TV is talking to me, but it is. So we're just going to continue pretend it never happened. So in terms of visceral pain, as I mentioned previously, the visceral pain is mostly caused by either stretching, distension, or compression of internal organs. It is very often a debilitating, noxious pain. It can be associated with other very poorly tolerated symptoms of nausea, vomiting. And, in early stages of visceral cancer pain, it can be appropriately managed with pharmacological agents. However, as the cancer progresses, those usually do not help much. So that's when a time comes for considering of either neurolytic sympathetic blocks, or potentially, if the patient still is expected to live for quite a few months, intrathecal therapy, which we're going to talk about in a little bit as well. So there are different types of neurolytic blocks, and they vary depending on which organs you are interested in affecting. So for upper abdomen, celiac plexus block is the most commonly utilized block. It covers essentially every organ in the upper abdomen, all the way, through the small intestine and through first proximal half of the large intestine. So a lot of different organs, as you can see. Now, for pelvic pain like this patient is experiencing, superior hypogastric plexus block would be more appropriate. It covers all the pelvic organs, uterus, bladder, lower gut, ovaries. And if the patient also has associated perineal pain, if this cancer involves her perineum or rectum, ganglion of impar block would be appropriate. Superior hypogastric block, as mentioned, covers all the pelvic organs, so uterus, ovaries, vagina, bladder. Those type of procedures on in-house patients are usually performed by interventional radiology, and they are fantastic at it. We do perform, the pain clinic also performs those kind of imaging and procedures under the fluoroscopy. However, CT-guided procedures are often safer and more precise. So the way that this block is conducted, we go at the level of L5, the lowest lumbar vertebra, and we pass next to the spine from the back towards the belly, all the way anteriorly to that lowest vertebra where the superior hypogastric plexus lives. Now, in terms of ganglion of impar, as mentioned, it is specifically for perineal and rectal pain, also performed by the same services. There are two different approaches for this particular procedure. One is transcoccygeal, and this is where the needle is pointing, so we go directly through the disc, injecting medication right on the inside part of the sacrum. Alternatively, one can curve the needle and go through the anococcygeal ligament and put the medication sort of with a curved needle this way. Both of those blocks can be performed initially with local anesthetic to assess if there is actually improved analgesia following the procedure. And if that is the case, this can be followed by injection of either alcohol or phenol, which then simply destroys those nerves and provides long-lasting pain relief. Let's move to the next case. So this is Mr. Smith. He's 68-year-old male with a known history of pancreatic cancer with worsening abdominal pain. Patient is already on large doses of opioids. He's also using some adjuvant medications. However, he reports a lot of opioid-related side effects that he would like to minimize. Opioids are helping him quite a bit, but he is experiencing severe sedation at those doses, as well as some constipation. So this is, we're in quite a bit of a pickle, because what do you do with a patient like that? Well, there are options, and the option is intrathecal opioid administration. So the key here is, instead of providing medications via IV or orally, one can administer opioids directly in through the intrathecal space, where they're supposed to act on the receptors in the spinal cord. So you're putting them into the fluid surrounding the spinal cord, and as such, the benefit of it is that you have a hundredfold decrease in the amount of opioid required. So let's say if this patient is taking 500 milligrams of IV morphine, that will only equal to 5 milligrams of intrathecal administration. And what comes along with it is decrease in all of those opioid-related side effects: sedation, nausea, constipation, all of them except one, which is related to the effects of opioids on the spinal cord, and that would be itching. Sometimes itching certainly can get worse. In order to undergo implantation of intrathecal pump, the patient has to suffer from intractable pain, whether malignant or non-malignant, or suffer from intolerable side effects of opioid therapy, so like this patient. And ultimately, I think the most important aspect of this care is that this patient has to be responsive to opioids. So if the patient does not respond to opioids orally or via IV, there's no reason to think that if you put it into the intrathecal space, that there will be a different outcome. So if the patient doesn't respond to opioids, they are not good candidate for intrathecal therapy. But if they do, then you can certainly diminish the amount of opioids the patient has to take every day by putting the pump in. And we are so fortunate at UNC that we finally have a neurosurgeon that specializes in nothing but neuromodulation therapy. And it's Dr. Vibhor Krishna. He's one of our new neurosurgeons. He implants intrathecal pumps as well as spinal cord stimulators and deep brain stimulators, and we are just very, very excited to be able to work together with him. Now, one requirement for intrathecal pumps that has to be, that should be part of your evaluation is whether or not the patient is expected to be with us for a certain duration of time. And it is said that usually, it makes sense to implant intrathecal pumps if the patient is expected to be with us for at least 3 to 6 months following implantation. Okay, so Mr. Smith underwent intrathecal pump implantation and did well for 6 months. Unfortunately, his malignancy now metastasized, and he's reporting severe abdominal pain. And the intrathecal pump is no longer working despite escalation of the dose. What is it that can be done? And we actually has touched on it briefly when we were talking about the blocks. I might have mentioned to you that for treatment of pain related to malignancy of organs in the upper abdomen, the celiac plexus block is ideal. Celiac plexus block can be accomplished percutaneously, either coming from the posterior aspect, from the level of the spine anteriorly, or reversely coming through the abdominal wall. So as a pain doctor, I do it in a fashion, I basically start at the back and move towards the abdomen. The celiac ganglia lie on the anterior aspect of the aorta. So you have to go very, very deep with those needles to find that ganglion. And occasionally you actually have to transect the aorta. And they get into, some trouble with that. Therefore, this procedure is certainly safer when done under CT guidance. So you can clearly see how deep those needles have to go. They have to pass the spine, past the aorta, which is right here, in order to target that ganglion. The alternative to this procedure would be to go transabdominally or endoscopically by inserting probe into the esophagus. So our interventional radiology performs those procedures under CT guidance, from the back towards, aligning the needles along the spine, versus our interventional GI service offers the same procedure performed endoscopically through the esophagus, which is also very safe and well tolerated by patients. So choose interventional ablative pain procedure most suitable for treatment of pain in patients suffering from a metastatic bladder cancer with peritoneal involvement. So just as a reminder, celiac plexus block is for the upper abdominal organs. Hypogastric block is for the pelvic organs. And those of you who chose hypogastric block are listening to the lecture and are correct. And this was not an easy question for you. So good job. Celiac plexus block would be great, however, for the upper abdominal organs. All right, case number 3. Let me just sneak a peek of how much time we have. Okay, not too much, so we're going to get through it. 75-year-old male with long-standing history of indolent prostate cancer presents with new onset low back pain, which interferes with gardening. So, of course, prostate cancer, the first thing that comes to mind is that this poor person likely has metastasis to the spine. However, he's 75 years old. It's also possible that he simply has degenerative disc disease and his back's hurting. So what do we do? What's our plan? I think the first thing that I would do is, of course, get x-rays to rule out metastatic disease. It's very unfortunate for him. We obtain imaging, and we notice that there are T5 and T11 vertebral compression fractures that could be explaining his pain. And there's evidence of tumor involvement. So what would we do next? How do we treat it? Well, I think the first step to take is to provide this patient with adequate analgesic for pain control as you are working on further therapeutic advancements. So another analgesics that are also very helpful when it comes to bony involvement are the bisphosphonates, which I'm sure you use very frequently for your patients with bony cancer, as well as intranasal calcitonin. So you implement all of those and, of course, refer the patient for radiation therapy to treat those compression fractures. Radiation, sometimes it is curative, but usually, always, it provides analgesic benefit when used as a palliative intervention. Pain relief is very common. The fractures are often stabilized. It is done in an attempt to prevent future fractures and to limit the bony tumor invasion. And it's extremely helpful under those circumstances. Following radiation therapy, most of the patient's pain resolves. His pain at the thoracolumbar junction at the T11, T12 does improve, but he continues to complain of that pain higher up in the spine where he has the T5 compression fracture. He's already on a decent amount of opioids as well as adjuvant medications. He doesn't like them very much. They make him dizzy and confused. He has completed calcitonin. He's still utilizing pamidronate, but ultimately he's interested in any interventional procedures that you can offer him for this problem. So what would we do for him? Well, I think vertebral augmentation procedures such as vertebroplasty and kyphoplasty are fantastic options for patients with various causes of vertebral compression fracture. Very often, vertebral compression fractures are caused by tumors, but they can also be attributed to multiple myeloma, painful hemangiomas, or even osteoporosis. So how do those two therapies differ? So both of those procedures are percutaneous. Both of them involve using a trocar inserted through the pedicle into the compressed, fractured vertebral body. Now, the difference lies in what happens after that. In vertebroplasty, all that is done is you put the trocar in, and then you inject cement, hopeful to prevent further compression of the vertebra, further fractures. Now, with kyphoplasty, that's a younger sister of vertebroplasty. What they came up with is that after you put the trocar in, you can inflate a balloon and open that space up a little bit and then fill that space up with cement, which in theory can even, elevate and certainly prevent future fracture in this vertebra. In our institution, interventional radiology does a fantastic job. Those procedures are available to your patients. There are some potential associated complications, which can be very drastic. However, overall, this is a very safe procedure, and the patients that I have referred for those procedures have excellent outcome, excellent analgesic benefits. So patient underwent a successful kyphoplasty. He returns to you reporting improvement in mid-back pain, but complains of a new onset pain radiating from mid-back all the way around his right chest. He describes it as electric, lancinating, burning. What do you think is going on? Well, it certainly sounds like some type of neuropathic pain. So what kind of neuropathic could it be? Could it be further metastatic involvement, maybe with neural compression? Could it be due to vascular compromise and hypoxic nerve injury, maybe the tumor's pressing on some vessel, some artery? Could it be post-radiation neuropathy? Well, I don't know about that. Maybe. Could it be chemo-related neuropathy? No, probably not likely. Chemo-related neuropathy usually shows up with nerve pain in the distal small nerves, such as in hands and feet, so probably not that. It certainly could be post-herpetic neuropathy or herpetic outbreak related to patients' immunosuppression. Yes, cancer patients certainly have possibility of developing those kind of issues. So this is probably like the most appropriate differential diagnosis for this patient. So we'll have to figure out what's going on and ultimately treat his condition. So how do we go about it? I think the first thing that we need to do is obtain thoracic MRI. MRI thoracic spine was done, and it shows no advancement of metastatic disease. So that's good news for our patient. However, he's an elderly gentleman, and he has a new disc protrusion impinging on the right T7 nerve root. So what do we do for that? Well, you certainly can send them to one of the pain doctors at UNC. So for this sort of issue, we often provide epidural steroid injections. We can perform those at any level in thoracic, cervical, or lumbar spine, and usually they work pretty well by decreasing inflammation around those nerves and providing relief. We also use epidurals for other issues, mostly perioperatively. Those epidural injections are not single shot. We thread catheters to provide a band of numbness by infusing numbing medications such as lidocaine or bupivacaine into the epidural space. The reason why I'm pointing this out in terms of cancer patients and chronic pain management is because in some instances, we use the same procedure for palliative care. For patients that are terminally ill, that are expected to depart, to leave us within a short duration of time, those procedures can provide final and very successful coverage for their pain during those terminal days. So the patient undergoes uneventful thoracic epidural with steroid, unfortunately without any success. It did not help. And the patient says, well, doc, is there anything else that you can do? It hurts so bad that I cannot sleep at night. Well, are there any other procedural options? Well, certainly. So for any patient that suffers from neuropathic pain, and that is neuropathic pain only. So it's very different from intrathecal pump, which infuses opioids for any diffuse body pain. That neuropathic pain has to be localized to either a single dermatome or to arms or legs and caused by some sort of injury or dysfunction to the nerves. Implantation of spinal cord stimulator relies on placing leads over the dorsal columns and then sending small electric impulses into the spinal cord, kind of overriding the sensation of pain. So that certainly would be a great option for this patient. Gonna skip off that. Okay, we have another question. You are trying to help a patient suffering from indolent form of myeloma with severe diffuse bony pain, but no vertebral compression fractures on imaging. The patient is responsive to opioid medication, but suffers from severe opioid-induced constipation. What interventional therapy would be most beneficial for this patient? Would it be spinal cord stimulator, intrathecal therapy, epidural steroid injection, or vertebroplasty? You are all right. Absolutely. This would be the best option for this patient. Okay, final case. Am I past my time frame? A little bit, but this is literally 2 slides. So 58-year-old male status post-resection of pulmonary tumor returns to you with severe upper extremity pain. And I know this says left, but let's pretend it says right because the picture is on the right side. So you notice also significantly, enlarged supraclavicular mass. What could this be? Of course, it is nothing good. Yes. So this poor patient had lung cancer and now is returning with this huge supraclavicular mass in the upper chest, which signifies Pancoast tumor. This tumor involves his entire brachial plexus, and the patient now has this horrible pain extending down his right arm. So what can you do for this patient? Well, you could do a few things. You could potentially refer them for implantation of cervical spinal cord stimulator. And that would be the option number 1. However, if the spinal cord stimulator does not help and the patient is really sick and terminal, there's always possibility of implanting a regional catheter for continuous infusion of numbing medicine. So just the same as we can do this with epidurals for truncal pain, if somebody has either lower or upper extremity pain, we can put a peripheral catheter next to the brachial plexus that continuously infuses medication, lidocaine or bupivacaine, to provide complete numbness in that extremity in pain. So in summary of this talk, I would like to mention that cancer pain is ubiquitous, severe, and undertreated. Cancer therapies and surgeries often contribute to chronic pain. Opioids remain the cornerstone of cancer pain management, but should never be used as a sole agent. And multimodal treatment options, which include pharmacological, rehabilitative, interventional, and psychological interventions, should be considered when approaching cancer pain. And if you are getting yourself in trouble and things are becoming too difficult, please consider referral to either palliative care or UNC pain doctors. Thank you so very much for participation in this talk. It was a privilege to talk to you, and I am willing and open to answer any questions you may have.
Thank you so much, Dr. James. This was really informative. We appreciate you being here with us this evening. So please, any questions for Dr. James, put them through poll everywhere. And if you guys have a few extra minutes, I know we are approaching the top of the hour. So thank you for hanging on a few extra minutes for some questions. So while we wait a few extra minutes, so someone who has referred people for celiac plexus, I find there's mixed results with benefit from this, and I find it mostly beneficial for patients who with pancreatic cancer that may radiate to the back, and then even whether it helps or not, and the percentage of that helping. So any comments on that?
Well, as everything else, nothing is 100%, correct? So that includes all procedural intervention. And that's why in my talk, I sort of highlighted that, some things help, some things didn't help, because that is real life and that happens all the time. I think the important aspect of interventional care is first to try the block with a local anesthetic to determine whether the patient will benefit from the block in the first place. Very often for patients suffering from cancer, there's so many different pain contributors. It could be from visceral organs. It could be from the abdominal wall, due to metastases. It could be just due to deconditioning or degenerative processes that are ongoing. And sometimes we just do not get the kind of an outcome that we expect. Saying that, even in any of my patients, whether those are cancer patients or just chronic pain patients, to me, achieving 50% relief, I'm simply ecstatic. And I'm usually content to receive, 30% benefit from any procedures that we do, because pain is just so challenging and patients often, appreciate any relief that they get. Now, I think for all those folks who are listening to me, the most important thing is to discuss with the patient possibilities, so the patient also has realistic expectations, because complete pain resolution is hardly ever possible.
Yeah, true. Very, very valid point. Thank you. Mm-hmm. So a question that has come in: how often do you see patients develop opioid-induced hyperalgesia, and how do you address it?
It's interesting because I recently actually wrote and published a paper on opioid-induced hyperalgesia. And we talk opioid-induced hyperalgesia a lot, but I do not see it very frequently. I think there is a very quick development of tolerance, and I see it way more frequently than opioid-induced hyperalgesia. So, for example, even in perioperative setting, when we administer larger doses of opioids intraoperatively, those patients have 3 to 4 times the requirement for opioids postoperatively as the patients that receive less opioids. So there's definitely that aspect of care. I see that also with my chronic pain patients. Sometimes less is more. However, I understand that for cancer patients, it's totally a different ballgame. And I think you may be seeing, I do not see that many cancer patients. And I think since you guys see a lot of them, and those patients tend to be very often on huge doses of opioids, opioid-induced hyperalgesia is probably much more of an issue. Again, I think the key is right from the very beginning, neutralize multimodal analgesia, all those aspects of care, and try to avoid escalating opioids. And when without, of course, necessity of doing so. And if the patient comes back and you notice tolerance and the opioids are maybe not as effective as they used to be, instead of increasing the dose of that given opioid, consider opioid rotation to a different analgesic. So, for example, if the patient's on morphine, rotate them to Dilaudid or oxycodone, and we will be able to actually either keep the same dose or lower the dose successfully.
A final question coming in, as I know we're past 5 o'clock. I want to be respectful of your time as well, Dr.
Time if I'm not in a rush. Yes.
Okay, great. Thank you. Could you share a document with all the treatment methods?
I thought that this PowerPoint was available to you guys by PDF. Am I wrong? I'm happy to share it. If it isn't, I'm happy to. You're more than welcome to send this PowerPoint. You know, it's such a with all the treatment methods, there would be a book, you know, so many different options. But if you would like whatever is in this PowerPoint, I'm certainly happy to give you guys access to all of this information.
Yeah, they should have access to the PowerPoint slides. And just as a reminder, in about a week, this will also be available in the self-paced courses. So you will be able to reference back and have access to this talk as well through the UNC Learning Network website. And in the chat, you could see that the handouts are available at that link. So you can pull that link before we end here. Let me wrap up by saying thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Center, and our Lineberger Cancer Network, especially to our telehealth team who are behind the scenes and make all this magic happen seamlessly. So thank you to Tim Poe, Benny Aburi, John Pell, Oliver Marth, Andrew Dodgson, Nadia Brown, and Patrick Muscarella.